Good evening. My name is Cathy Lewis and I'm the Chief Orthoptist at the Royal Children's Hospital in Melbourne. And I'm looking forward to chatting with you about some of the common tests an orthoptist will use in the eye clinic when testing children with glaucoma. Now, these tests are performed at the start of the eye examination, and I'll be focusing on the ones we use on younger children under the age of 8. I'll also chat about some of the strategies which might make the eye examination less stressful, and I'll provide some resources which you can access for support. And there will be time at the end of the presentation for me to answer any questions you'd like to send through. So to start off with, I'm going to give a brief overview of visual development in children, as this will help explain why we choose to do certain tests. So babies are born with an immature visual system. They see in black and white and shades of grey, and everything is quite blurry. And the structures in their eyes and the visual system, which include the cells in the visual cortex of their brain, need to mature and develop, and they require stimulation for the child's vision to develop normally. Now, as the vision improves, the eyes become aligned and they learn to move together and work together, which enables that binocular depth perception to develop by about 6 months of age, which we call stereopsis. This then supports the development of hand-eye coordination and spatial awareness. So there's a lot of visual development occurring within the first months of life, and the younger the child is, the more plastic the visual system is. And this plasticity reduces towards the age of 7 or 8 years, and the vision tends to stabilise around this age. Now, there is a small amount of plasticity into young adulthood, but most of the development occurs prior to the age of 8. So we need to monitor the visual development in your child with glaucoma to make sure it stabilises at the best possible level. Now, if something interrupts the visual development during those first 8 years of life, it may lead to what we call amblyopia. And amblyopia is a reduction in vision that remains after the pathology or obstruction is removed or corrected. Now, we can treat amblyopia and train up the vision in the weaker eye, often by patching the stronger eye for a certain amount of time each day, but this treatment is less effective as the child approaches the age of 7 or 8 years. So the earlier the diagnosis and treatment of amblyopia, the better the visual outcome for the child. Now, glaucoma affects the eye differently in children compared to adults. The child's eye is susceptible to that stretching under the high intraocular pressure, while the adult's eye suffers damage primarily to the optic nerve. And possible obstructions to visual development in children with glaucoma, which may lead to amblyopia, include the corneal scarring, which may occur if the eye rapidly grows due to that high intraocular pressure. And this can affect the way the light is entering the eye. And changes in refraction can occur if the size or the shape of the child's eye changes due to that high intraocular pressure stretching the eye out of shape. And this can then send blurry images to the brain rather than clear ones. And an eye that is misaligned or turned in or out or up or down, it will send less stimulation through to those vision cells in the brain, which may result in amblyopia in that eye. So an important component of monitoring your child with glaucoma is to detect, diagnose, and treat amblyopia early if it occurs. And therefore, assessing your child's visual acuity is really important. Now, visual acuity refers to the clarity or sharpness of your child's vision, and we often record it as a fraction. So the number on the top of the fraction refers to the distance in meters the child is sitting from the chart. So looking at the chart on the left, the results are provided for a 6-meter test because the number 6 is the number on the top of the fraction. And the number on the bottom of the fraction represents the line the child could see to. So if you look at the top letter A on the chart, the fraction beside it is 6/60. And this means the child was sitting 6 meters from the chart, but could only read the line you should be able to see from 60 meters away. So 6/60 is very poor vision. Now, ideally, we want the vision to develop to 6/6, as this means sitting at 6 meters from the chart, the child could read the line you should be able to see from 6 meters away. And a lot of visual acuity testing on children is performed at 3 meters as we get better concentration and cooperation with the vision chart placed slightly closer. So therefore, the number on the top of the fraction for children is often a number 3, and therefore fully developed vision would be the 3/3. Sitting at 3 meters from the chart, they can read down to the line you should be able to see from 3 meters. Now, if you look at the table on the right-hand side of the screen, you can see the level of vision a newborn has is 6/240 meters, which is extremely poor vision, but normal for that age. And somewhere between the age of 6 months and 2 years, the vision will reach 6/6 with normal development. Now, there's several ways for us to test the vision of babies and young children, and the tests are carefully selected based on the child's age and cognitive ability and cooperation. And they can be broken down into quantitative and qualitative methods of testing. So the qualitative methods of testing are based on observation and will provide a description of the visual function of your child. So this is a common way of assessing a very young child or less cooperative children. And the assessments don't tell us the level of visual acuity, so they don't give us a fraction, but they do tell us if there is a difference in visual acuity between the eyes, which can indicate amblyopia, and therefore we can start treatment. So we can compare how the child reacts when we cover one eye at a time, as they will often get more upset when forced to look with an eye that has poor vision. We can put prisms in front of the child's eyes to give them double vision, and we watch their eyes to see how they respond. And we observe how the child reacts to bright light being shone into each eye. And if the child has an eye turn, we can observe which eye is turning and how often, as the one eye turning all the time could indicate the presence of amblyopia. And here are more examples of vision tests that describe visual function. We can use a rotating drum with vertical stripes to see if the child follows the stripes with one eye at a time and if there's a difference between the eyes. We can use interesting toys to see if the child is fixing centrally and following the toy with one eye at a time equally well. And we can see if the child can find small objects of different sizes with either eye. So don't be alarmed if we're unable to measure the level of your child's visual acuity, because there are so many ways that we can actually determine whether amblyopia is present or not, and that's what's important. Now, quantitative visual acuity tests do measure the level of visual acuity and they provide that numbered result. So you're often getting a fraction. And the 3 main types of preferential looking tests are shown on the slide. So they all look different, but they use the same principle. And that is to show a card that has a pattern on one side and no pattern on the other side. And the child will automatically look towards the pattern if they see it. And this pattern gets finer and finer, which will give a level of visual acuity. Now, these tests are mainly used on infants and younger children, but they can be used on older children who are unable to be tested with traditional vision charts. And these tests are designed to be performed within 1 metre, as the infant's concentration and cooperation is best up close. Now, as the child gets older, they learn to match symbols or letters or identify them by name, and this enables us to use more traditional vision charts for testing. And we can test the child's vision in the distance at 3 metres and for near at 40 centimetres. So it's important when testing children, we practice up close first to ensure that the child understands the test. And that way we know that any incorrect responses during the vision testing are due to the child not seeing the symbol rather than not understanding what to do. And here are some examples of common paediatric vision charts that you might see when you're visiting the eye clinic with your child. And as I mentioned earlier, a turned eye can lead to amblyopia, and children with glaucoma have a slightly higher risk of having an eye turn. So we regularly assess their ocular alignment. And a quick way to do this is by having the child look at a bright light which we hold in front of their eyes. And we observe where the light reflection is in the child's eyes to see if they are symmetrical. An asymmetrical light reflex often indicates an eye turn. So looking at the close-up images on the screen, you can see the eye to your right is turned outwards, and the light reflex in that eye is displaced inwards, closer towards the coloured iris. So this would indicate an outwards eye turn, and that eye would possibly have amblyopia. Now, the gold standard way of testing ocular alignment is by performing what we call a cover test, where we cover one eye while the child looks at a target at near or in the distance. And we then watch the uncovered eye to see if it needs to move to take up fixation or to look straight ahead. And any movement is an indication that the eye is out of alignment. And then we repeat the process covering the other eye. So looking at the close-up images on the screen, once again, you can see the eye on your right is turned outwards. Now, if we covered the eye on your left, the eye on your right would need to move inwards to look straight ahead. And it's that movement which would indicate an eye turn, and that eye could have amblyopia. Now, if we do find a turned eye, we can estimate the size of it by looking at the position of the light reflection in the eye. But the more accurate way is to measure it using prisms, and you need about 4 arms to do this test. So I often use siblings or parents to help and cover my face in stickers to give the child something fun to look at up close. And just keep in mind there are lots of different types of eye turns. Some lead to amblyopia, some do not. Some are corrected with glasses, some require surgery, and some never need any treatment. Now, there are 6 muscles on the outside of each eye, which we call extraocular muscles, and they all work together so that the eyes can move symmetrically without seeing double vision. And we assess these muscles by observing the eyes as they move in 9 positions of gaze. With the older child, we'll use a pen light so we can see that light reflex in the eye in all the positions. And with the younger child, you can see me here in the photos using a toy to keep their attention. Now, we also then want to determine whether the eyes are actually working together. Is the brain getting one image from each eye and joining or fusing them together into a single image? We can test this by putting a prism up in front of one eye, which gives the child double vision, and then we look for a corrective movement, which proves the eyes are working together. And then that would indicate that there's less possibility of amblyopia being present. Now, this is a great screening test as it's quick and easy to perform, and it can be used on children from 6 months of age. And then once we know the child can fuse, we want to test to see if their binocular depth perception or stereopsis has developed. And as I mentioned earlier, it should have developed by 6 months of age, but it may not develop normally or at all if the child has amblyopia or a turned eye. So there's lots of different tests we can choose from to measure stereopsis. The one at the top, the Lang stereo test, is probably the most common one to use for screening younger children, and many of you may already have come across this. It's quick and easy to perform, and it doesn't require the child to wear glasses. They simply point to or say the name of the image that they can see on the card as they sort of come out in 3D towards them. So all of these tests have been a summary of the baseline tests that we would do on most children coming to an eye clinic, and they can be done on children of all ages. And we would do these on children with glaucoma. Now, there are several additional tests we perform on children when monitoring glaucoma to assess if there is any damage to the back of the eye, which is the retina and the optic nerve head, due to that raised intraocular pressure. So we can use special cameras to photograph inside the eye to document what the retina and optic nerve head look like, and we call this fundus photography. Now, the child must sit still while a bright light flashes as the photographs are taken. So this requires a certain amount of cooperation and often not possible in clinic on children under the age of 3 or 4 years. And the OCT scans the layers of the retina and the optic nerve head, which are invisible to us when we're looking directly inside the eye or looking at those fundus photos. So it's scanning these hidden layers underneath that we can't see otherwise. So this machine requires the child to sit still once again and look at a bright light while those scans take place. Now, when testing children around the age of 3 or 4, we can change the settings to take faster scans, but they are lower quality. So from the age of 5 or 6, as a child's cooperation improves, we can take slower, better quality scans that give us more information. And there's also machines which map the visual fields to detect any visual field loss due to that high pressure in the eye. Now, this requires very good cooperation throughout the testing, which takes several minutes on each eye, and therefore not often reliable until about the age of 10. So we tend not to use this test prior to that age. So all of these tests require cooperation and are not possible to perform in clinic on the very young children. So for these reasons, measuring intraocular pressure is a valuable diagnostic tool in monitoring children with glaucoma, as it can be done on children of any age. So at RCH, the Royal Children's Hospital, we use the eye care shown on the screen. It's an older model, but we prefer using it. Just find it easier to get a measurement on children. It gives a digital reading and has a tiny probe that bounces quickly on and off the surface of your child's eye, which you can see on the bottom left of the slide. So it doesn't hurt, so it's used without using any anaesthetic eye drops, which is great. And the probe is so tiny, it just fits easily between that narrow opening of the child's lids. And the probe speed is so fast, it takes measurements between the natural blinks of your child's eye. So we aim that probe to hit the middle of the cornea or the front of the eye in the middle there, and we get an alert if it's not in the correct position. So this technique requires a relaxed child, as crying or squeezing the eyes can alter that pressure, which is also why we try and avoid forcing the lids open to perform the tests. Now, if we can't get a measurement and we can feel, if we can't get a measurement, we can sort of feel the eyes over the lids, feeling for any gross difference in pressure between the eyes. And we always take into consideration the results of all the tests performed on the day, as all of them help provide information on your child's glaucoma control. And any information you, the carers, provides us is just as important. You know, your child might be more light sensitive or irritable or grumpier than usual, and they could all be signs of that raised intraocular pressure. So at the end of our examination, if we haven't been able to measure the intraocular pressure and we're concerned about the glaucoma control based on the medical history that you give us, the information, and the findings of all the tests we've performed, we have the option to bring the child back to clinic later the same day or on another day to try again, or book them in for an eye examination under anaesthetic. And under anaesthetic, we can measure so much. We can measure the intraocular pressure, we can measure their refraction to see if the eye is stretched out of shape. We can look for corneal scarring, we can look inside their eyes at the fundus. We can take photos inside their eyes and even OCT scans if indicated. So there's a lot we can do. We can't take the visual field test under an anaesthetic, but otherwise we can perform a lot of tests. But ideally, we'd like to avoid an anaesthetic if possible. So let's look at some strategies which might help with this. So here's some tips which may or may not be useful to you, as all children are unique and each situation is different. And what is important is finding what works for you and your child. So please know we understand it's not always possible to perform the tests that we want to perform, no matter how well prepared you, the family, are, or how well prepared we think we are. So we just do our best on the day. But for the youngest patients, being well fed and well rested is a good way to start. And frequent visits, if handled well, can increase familiarity and decrease the stress for the child and the carer during the testing. And as you all probably know, eye appointments can take a long time. So taking some drinks and snacks and something to entertain your child, like books and toys, can come in handy, as all of this promotes a positive environment for your child. And children often pick up on the mood around them. And I know this can be super difficult, especially when you're worried about your child's visual development. But promoting a relaxed, calm environment can also be beneficial for the outcome of the examination. And for those of you with more than one child, and this does depend on the personalities and age of your children, but I love it when older siblings attend the appointment, as I love using them throughout the examination. As younger siblings tend to be really interested in whatever their older siblings are doing. And the older child can help by distracting the younger child with toys or soap bubbles during the intraocular pressure testing. They can show how easy it is to put a patch on for a vision test, and they can hold targets in the distance when the orthoptist is testing that ocular alignment. And this is where practicing at home can come in handy too. So when you practice at home, you can include the older sibling as well. You can practice covering one eye at a time. You can practice getting them to fix and follow a toy, just like we would do in clinic. And as your child gets older, you can get copies of the vision chart symbols to practice matching at home or practice saying the names, learning what they're called. And we also know research has shown that using affirmative language with a child will lead to more positive outcomes. So, for example, reflecting on the language we're using leading up to an appointment and within the appointment, and thinking rather than using negative language like "be good today or you'll get in trouble," you could rephrase it with positive language like "if you do a good job today, I'll be so proud of you." Now, what child wouldn't want to cooperate when they hear that? Probably lots. But anyway, it's important to think about what motivates your child. Perhaps your child responds well to a reward. Some children like an instant reward, a sticker, or a treat on the day, and some prefer a delayed reward and goal setting. So it's all about what motivates your child. Now, if possible, try and avoid things that may trigger a negative response in your child. And you may need to chat with your eye care team about this if there is something that your child is experiencing during their eye examination that really upsets them. Perhaps there is something that can be done differently. And this actually takes me on to my final slide, which then provides some resources for you to consider. So we know that examinations can be uncomfortable and invasive, and some children really don't cope with the situation. And at the Royal Children's Hospital, we refer these children to a child life therapist or educational play therapist, they can be called. And they attend the appointment with the family and the child, and they do an amazing job creating a positive experience tailored to the child's specific needs. So if you have a child who is often distressed by their eye examination, I do recommend you discuss this with the ophthalmologist and discuss the possibility of a referral to a child life therapist. Now, Glaucoma Australia, as we all know, do an amazing job providing education and support to children and adults with glaucoma. And on their website, you'll find a link to the fabulous talk on childhood glaucoma, which was presented by my clever colleague, Dr. John Ruddle, in March this year. I highly recommend you watch this if you haven't already done so. And Glaucoma Australia have a Facebook support group for children with glaucoma, which provides a platform to meet others in a similar situation, which can be really useful. And I've provided a link to the RCH Ophthalmology Department website, and here you can find patient information sheets and patient resources, as well as a link to the video, What Happens When I Have My Eyes Checked. And you can also access this video by scanning the QR code on the screen. We've created this video to explain what happens during a typical eye examination in our clinic, and that can be a useful resource for both children and their adult carers. So that takes me to the end of my presentation, and I see some questions have come through, so I'll do my best to answer them in the time we've got left. So let me see. So apart from the baseline eye exams, are there any extra tests for glaucoma detection and progression and management? And so I think that I did include most of those in the presentation. And so yes, intraocular pressure definitely is one that we like to do and can do from a very young age. And then we have the additional tests such as the retinal photographs, the fundus photography, but that sometimes we're lucky and we can get that done from the age of 2 or younger, but often it's around the age of 3 or 4 we can start taking those photos, and they do document what the inside of the eye is looking, so it makes an easy reference point when we have that photography to refer to each time. That OCT scan of the hidden layers of the back of the eye is also one we like to get onto as soon as the child can cooperate, because it's just showing perhaps some damage is caused by the pressure that you actually can't see otherwise. So it's giving a really early indication of damage. And then also we've got the visual field testing, but that does come later. We haven't had a test designed yet that's accurate enough to be performed on the very young children. So they would be the main tests. Question 2, how do you determine when you will need to dilate pupils as part of the examination? That's a great question. I didn't answer that during the presentation today, I'm sorry. So that is, think of your pupils, the black parts in your eyes, as a window into your eye. They're literally a hole into your eye. And so the bigger that window, the bigger the view we get inside our eyes. So we put the drops in the eyes to make those pupils large, and then that gives the doctor a really good view inside the eyes, and it can help make the fundus photography and the OCT measurements easier as well. So we have drops to make the pupils larger, and we also have drops that stop the child from being able to focus. And when we paralyze their focusing, we can then take a measurement with a special tool that measures for short-sightedness, long-sightedness, and astigmatism. And you may remember I mentioned about the eye stretching out of shape. That is the eye stretching. If it gets too big, the child becomes short-sighted. If it stretches out of shape, then they can get what we call astigmatism. So we have drops so that we can measure for that, and drops to get those larger pupils. Why does my child need extra orthoptic testing? So those tests that I covered at the start of the presentation, it's to talk about how the child's visual development is progressing. And that's what's really important for us, because we know that there's that plasticity in the visual system under the age of 8, and we don't want anything to affect that visual development if possible. So that's what all of those extra orthoptic tests are for. Are the eyes straight? Are they working well? Is my child's vision developing as quickly as it should, or as it should? So that's why we keep using those other non-sort of glaucoma monitoring tests, but in a way they do monitor the glaucoma, because if the glaucoma, if the pressure's high, it may lead on to the amblyopia, which will then affect the visual development. So it's all part of putting together a big picture so that we can really get a good idea of how your child's glaucoma is being controlled and how the vision is developing. What if my child is having a bad day and you can't perform an intraocular pressure test? Will you do another test that day? So we do look at all the tests that we're able to perform on the day to put together a picture. So sometimes there isn't any other intraocular pressure test we can do other than sort of feeling the pressure within the globes physically by putting our fingers on the child's eyes. And if we're unable to get any intraocular pressure test that day, then the ophthalmologist will make a decision based on all of those other tests that were performed that day, plus your feedback. And if they're concerned about the control, then they're going to make a decision, how quickly do we need to bring the child back to retest it and try again? Or do we actually need to book your child in for an examination under anaesthetic? So it does really depend on what that whole picture is looking like. You know, if your child's vision is developing really well, they can't see any corneal scarring, they haven't been able to find any refractive error, like the eye hasn't been pushed out of shape, then there would be, and if your child's not grumpy or anything, then there's sort of less stress to measure that intraocular pressure as quickly as we might have done if there were other signs that the pressure's not being well controlled. So if there was the corneal scarring, or the eye had been pushed out of shape and you could see it was getting bigger, or we could measure that, then you would want to do that intraocular pressure test sooner rather than later. So we're just putting together the results of all the tests we have been able to do. How can I support my child when the practitioner is attempting to check their pressures? I think this can be a really stressful situation. I know it can be really hard. And the main thing is for you to try and just stay calm. Just try and stay calm. Even if your child's screaming, just try and stay calm. If you know your child responds to certain music and that calms your child, you might want to play music during that time. Or if there's a way to distract your child, as I mentioned before, if you have an older sibling, get them standing in the distance behind the practitioner's head sort of thing to distract the younger child. But it's all about just trying to stay calm yourself. And the ophthalmologists, they're used to trying to get a measurement in that sort of situation. So don't worry, don't get upset. It's a common situation for us. And it's just a matter of trying to remain as calm as possible, which is, I know, easier said than done. And yeah, the distraction method with the child, if they're depending on how old they are, can be quite beneficial. Any tips on how parents and children can emotionally prepare in the lead up to the appointment? So I think depending on how old your child is, I'm assuming this is for an older child. And I think just being honest with them and educating them about what is going to happen. And if you know that we're going to be using eye drops, I don't think there's it's useful to say they don't hurt or they don't sting, but you might mention that we might need to put the eye drops in so that children are aware and that they might be, that they might tingle. But we need to put the drops in so that we can see if the eyes are healthy or how the eyes are going. And it's a matter of chatting about it and chatting with your child and asking them what they think about it and how they're feeling. And you might want to click onto that video that we've created on the RCH website so you can go through that together, and that gives you the opportunity to stop at certain parts and have a chat with your child. But I think education is a good thing, so things don't come as a surprise to your child. How can parents help the eye care professional get the most accurate results and make the appointment a positive experience for their child? I think once again, it is just a matter of remaining calm and listening to the instructions that the eye care professional is giving you. So I would just try and remain calm and let the child interact as much as possible with the eye care professional and let the child build a relationship. And so you're sort of there and quietly in the background to support them if possible. So I think that can be a good way to do it. And as I mentioned earlier, use siblings whenever you can. And if it is an ongoing problem for your child, if it's very difficult, I seriously recommend asking about a child life therapist, because they really can totally change the experience for a child if you do have a child that struggles with their eye examinations and finds it a very negative experience. Are there any support networks available for families with children who have an eye condition? And I think the best support network is actually the one run by Glaucoma Australia, and I highly recommend you do check out their Facebook support page for children and with glaucoma and families that have children with glaucoma. I think there is so much to benefit from connecting with other people in the same situation. And as the children grow up, it might be very positive experience for them to also have that opportunity to connect with others in the same situation as them. So yes, please check out the Glaucoma Australia Facebook support page for children and families, children with glaucoma. And are there many parents you come across who are using the eye care home too for their child? If so, has it been helpful, and in what situations? I personally haven't come across any that use the eye care home too, but I know that some of my colleagues have. I know that Dr. John Ruddle actually has. And that was for situations for families that live quite remote and don't have access to a local optometrist, because sometimes you might be in a situation where you actually need to get your child's pressures measured quite often, and you're unable to come to the hospital for every one of those visits. And so we often recommend that you get, every second visit with your local optometrist and go in and get the pressure tested. Now, for people that live remotely or are often traveling internationally with their families, this can be quite difficult. So in those situations, it can be useful to have an eye care home too. But normally, most people would have access to some sort of eye care professional close to them so that they can get that pressure checked intermittently closer to home as needed. So it's not something that we come across very often at all, but for those families in certain situations, it can be quite helpful. And maybe there's an opportunity to rent them if you're in a situation where the doctor would like you to test the pressure quite often, sort of thing. If you're needing pressure tests very often, you might be able to rent one, but it's not very often that it's needed. So it's more for those sort of special situations. Okay, I think we have come to the end of the session for this evening. So thank you all for sending through those questions. They are great questions. And I'd just like to say thank you to Glaucoma Australia for inviting me to speak with you today. I hope you found it interesting, and I'm more than happy to answer any further questions that you may think of down the track and you'd like answers. So thanks once again for tuning in, and I hope you found it interesting and educational. Good luck.